out by asking, why should we be concerned with the angry patient? Why would we be concerned with them at all? Why aren't they just like any other patient?
Negative feedback spreads a lot faster than positive feedback.
Absolutely right, Todd. Negative feedback spreads a lot faster than positive. Somebody said about 10 to 1 or more. If you get one complaint, one piece of praise and 10 complaints is more the way it goes when it gets spread out. It goes viral nowadays too. So from a PR angle, it's important because angry patients will talk about their experience more than positive or patients that have had a positive experience. But what else? What other reason might there be?
Lawsuits.
Pardon?
Malpractice suits.
Absolutely. This is where the research on the angry patient came from. That's right, Val. That the angry patient is the most litigious patient, most likely to sue. Now, if you remember anything we talked about in the last seminar, what might be a critical factor in why a patient sues who's angry and why a patient who's angry does not sue? What would be a differentiating factor? If they like you or not. It's absolutely true. The relationship, if it's positive, with the office, with the doctor, but with the staff as well, if that relationship experience is positive, the patient who's angry is not likely to sue. How about another reason? Don't forget what Vail said. Patient is central. What might be another reason why we should be concerned with dealing effectively with the angry patient? Go ahead. You look like you have an answer. You're thinking, well, you look so bright, and you look like I know the answer, but I don't want to give it. Anybody want to think about that or share a thought?
Personal safety.
Well, personal safety is something I want to get to in the next time around. But what I was thinking about is attitudes, emotions affect care. So the angry patient may need to be addressed so that their care is effective. They may not be as inclined to comply. And we know that if you have a certain expectation or attitude, drugs and physical interventions and surgery, physical therapy, have a different effect on you. So it isn't as though we could put the psychology of it in a box and say that's something separate, that touchy-feely stuff. It really is connected to the physiology and the chemistry. And so the care that the patient gets may be greatly affected by if they're angry or not, what their emotional state is, what their mood is, what their attitude is. And then a fourth reason would be what Laurie said, for safety reasons. How many of you think we live in a violent society? I hope all of you do, because I'm afraid we do live in a violent society. Now, I haven't heard of a doctor's office being shot up, but we've heard of every other situation, including schools, churches, movie theaters, outside somewhere on the street. So I would like to say that that anger is a signal that there could follow violence. So I think we should be prepared for that. And later on I want to ask this, and Vail, I think you would be very important in considering this particular aspect. And that is, do we have a plan in the office if violence breaks out? So just let's think about that, and we'll talk about that later on. But that may be a very important consideration if we think that the angry patient may also lead to a violent outburst. But let me tell you a little bit about what I know about anger to set the stage and give us a context. And I know this from the research on anger, but I also know it as a clinician, as a psychotherapist. Anger is a two-sided coin. If I hurt you, what are you inclined to do back to me? Hurt me back, right? If I punch you in the nose, you're inclined to punch me back. Unless I punch you hard enough that you can't punch me back, right? But that's the side of the coin that we call hostility. And anger has that component. That's the component we're concerned about when we think about violence and we think about the unpleasantness of confronting someone who's angry. What's the other side of the coin? This is the side we forget about. What else has happened to you, Melanie, if I punch you in the nose?
You're hurt,
Hurt. You said the word. Pain. The other side of the coin of anger is pain. So the person who's angry is also hurt. If you address the hurt side of the situation, you're much better off. You're able to make progress. If you say, in effect, what's happened to you that's upset you, you're asking them to tell you why they're hurt. You can say, in effect, those exact words when we do that protocol. When you say, you look upset, what is it that's upsetting you? Has something happened that has hurt you? Disrespect is emotional pain. Disappointment is emotional pain. Were you asking a question? You bought it. This is an auction. So the two-sidedness of the two-sided coin of anger is a very important conceptualization. And the concept that anger is emotional pain. And to deal with the pain side is much better than to deal with the hostility side. If you're baited into being hostile back, you get into trouble. But that doesn't mean there isn't a place in dealing with the angry patient where you might set a limit. Okay? Let me tell you something that I've learned as a psychotherapist. Many, many years I would sit with a female client, a woman, and I would watch her cry, and I would hear words that didn't fit with the emotion that I was observing. When a woman is angry, she very often, I've observed, will cry. Now, you wouldn't interpret crying as anger, would you? But the expression there is of the pain side of the anger coin. That's why you're seeing that. With a male patient, what will you see? In the ER, they'll talk about somebody being upset and punching a hole in the drywall. Have you ever heard of that, Dan?
Yep.
It happens, right? So a male is likely to express the hostility side. So that's one demographic in working with the angry patient that you might want to consider. Am I dealing with a male or a female? Another demographic may be, does this person have a history of violence or mental illness? Now, with all the gun control issues, they're talking about the need to understand and have programs for mental illness. But only 4% of mental patients are violent and cause violence problems. So it's not a simple matter of saying, okay, if you have a mental health history, then you're going to be violent. It's not that easy, but it certainly is one indicator that we might pay attention to. If somebody has a history of being aggressive and acting out, we can say that that may be a signal that in a given situation, this person may act out again in that way to be aggressive. So we want to characterize the person without stereotyping. We want to find categories in which the person fits, where we might say, this angry person is likely to behave in this way. And those are just a few of the major characteristics. Just one other fact about anger that I would like to share with you. Anger can be a personality trait. How many of you know somebody who you would say, Alex is always angry. He's just always angry. Or she's always angry. Alex could be a woman's name, right? How many of you know somebody like that? So no matter what the situation is, I think maybe half of you have said yes to that. You know that that person, no matter what the situation is, if something rocks their boat, they're going to act in an angry way. So we have there a situation where we have a personality trait, and that's a management problem then. We're not going to change that person or change the situation. The management problem is, how do I handle that person? They're likely always to express anger. Maybe they need reassurance. Maybe the angry trait is fueled by fear, so that I would comfort them and protect them more than I would somebody else. So I need to know if it's a trait or if it's situational. It's easier to fix a situation than to change the personality trait. And that's an important differentiation. The third point down, Jack Schaefer's the recognition threshold. The concept there is, the idea there is that Most of the time, when we're dealing with a lot of people like you are in the practice on a daily basis, you become somewhat robotic-like in just doing your thing and processing the patient and not individualizing or personalizing as much as you could. What happens is we don't recognize when something is significantly different. It could be only a little bit different, but it's out of the ordinary. That's a flag for us. If we encounter someone that for some reason they seem that they're a little bit different than the ordinary patient, something else is going on here, there's something that I need to attend to that is catching my attention, that's an important flag to pay attention to, because you don't always see anger as a full-blown expression. You see it perhaps just that somebody doesn't want to look you in the eye, who might have a different tone of voice than you're used to, who doesn't readily give you their arm for blood pressure or manipulation when you're working with them. You could feel it, you could see it. It doesn't have to be way over the threshold. It could be just a little bit over the threshold, but it's recognizable, and then you might go into the protocol that we've laid out here, but we'll go through that. So one of the advantages of working with so many patients on a daily basis is that you get an enormous data bank in your mind regarding what patients are like and what to expect. So that when you see something that's a little bit out of the ordinary, that's a flag to pay attention to. And anger doesn't always present in a very expressive way. Sometimes it's very subtle, but it can lead to a very expressive reaction. Well, let's look at some of the cases that we have. Do you have any questions up to this point regarding what I've said? It's not brain science, as we say, or brain surgery, whatever. Yes, Mary.
I remember having a patient who had a knee scope, and fairly young guy. After the surgery, he developed a blood clot, and he was so angry that it was our fault, you know, and no matter what was said to him, it did not affect him in any way, and he became very threatening in his, you know, on the phone with me about getting us, you know, that type of thing, and it really scared me.
Yeah, that sounds frightening. If somebody carries it on that long, yeah, and also tells you on the phone that he's going to get you for this.
I mean, to the point where, as we were leaving the building, we were looking in the parking lot to see if he was out there.
Yeah, well, that's really a very typical angry patient protocol that you're talking about. What did you say? How did you respond to the person?
It's been quite some time, but we just tried to explain to him that, you know, what was important is that he be treated for the blood clot, you know. And
so you maintained a relatively calm demeanor even though he was being angry at you?
I did, but the doctor actually took over on the situation and called him and tried to talk to him, but there was no getting through to him whatsoever.
Okay, so he's gonna hold on to his grudge. He's going to remain, but I think the doctor calling was a good idea. I think follow-up is a good idea. We don't do enough of that. We'll talk about that afterwards. But let's say you processed an angry incident in a day and you felt, okay, we dealt with this and the patient left. I don't think it's inappropriate to call that evening that patient and say, how are you doing? I know you were upset in the office today. We're hoping that you're doing better. That would be very appropriate. Now, this person isn't going to say, I'm over it and everything's fine. He's going to hold that grudge. But I think remaining calm, showing concern. Now, as a psychotherapist, and you could practice this too, you don't need a license to do this kind of thing, you want to go a little bit beyond the obvious and read between the lines, okay? What else might be bothering this person? Rather than anger, what might be the emotion? Fear, absolutely. Fear is often behind anger. For a man, when they're afraid, they get angry. When they get afraid, they're going to fight back. So a blood clot to this person might, and he may have been told this, and it may be true, this is a very dangerous situation that you've been put into. Now I'm really afraid, but I'm not going to say I'm afraid because that's weak and men don't talk that way. So I'm going to be bravo and I'm going to say, I'm angry at you and I'm going to get you. So I guess I would interpret the fear at some point. This is very frightening. It usually frightens patients when they're told they have a blood clot. But we're doing everything we can. I think it's going to be okay. The doctor saying that would be very powerful. Am I on the right track?
Yeah.
Stay calm. Know that he's holding a grudge and you can't take that grudge away. maybe interpret the emotion as fear as well as anger. And at some point you have to let it alone. Now, if this person became more belligerent, vulgar, and picked on a person in particular, that's a place for setting a limit. That's a place for saying, I can't help you if you treat me that way. I can't help you if you react that way to what's going on. I'd be willing to do that. In the protocol, Drummond's protocol that we're looking at, there's a point at which he says, I think it's the fourth point, you say, what would you like me to do? Now, I don't know if that would have been appropriate for this fella at some point. Is there anything I can do for you to make you feel more comfortable? No, you screwed up, you gave me this blood clot, blah, blah, blah. Oh, I'm very sorry that happened. We're doing the best we can. Cut it off.
At what point would you call the police if there were just a downright threat?
A threat to your safety would be a time where you would say, maybe I ought to have the police come in. But I guess what I would look for in that particular case is that history. I'd want to know his history. Is there any history of violence? Could I talk to a loved one about, he's very angry, does he usually get angry? Has he done anything violent when he's angry? Has he gotten in trouble with anger ever before? And if you get yeses on some of those questions, then the lethality is up there. And then you might want to say, I think we should bring in safety, security, okay? But I would like to get that history. I wouldn't jump to get a cop in just because somebody's really afraid and angry. I saw a video when I was preparing for this presentation. Well, we looked up video, The Angry Patient, on the internet. You ought to look at that. There's some interesting videos. I didn't find any of them very helpful, but on one video, if we had a facility to do this, it would have been helpful to do so, is to show you this, because there's a patient waiting in the consultation room, the examining room, and he's an older man, he's very distraught, he's very angry, he's pacing. The doctor comes in, he's a young man, and he says, I've waited so long to see you, it's been an hour I've been in here, I told the receptionist I had to get back to the office, and blah, blah, blah. And so the doctor starts to explain, the doctor-actor, I guess, starts to explain why he was so delayed, that he had another patient that was across the way at the hospital and he had to deliver a baby or something. He never says to the patient, I'm sorry that you had to wait and I'm sorry that you're upset. He's very defensive in explaining all the reasons why what happened happened. And it was fake. It didn't work. You could see he was acting. You can't do that. I was worried about that, Todd, when you said, well, this happens, or this is what we told you this was going to occur, or something like that. You signed risk release papers and so forth. It doesn't help when somebody's afraid or angry to give them rational excuses for what happened, which are defensive of your spot. I think it would just be very dangerous to do that. You want to get out of protecting your situation, explaining your behavior, or having your ego damaged, and try to hear what they're saying and how they see it and what it is to them that you have to address. That's what you want to put into words. You want to change your perspective to their perspective. Where is Janet? Is Janet here? I think that Janet was the signature on the case that I got. No? This was the case of a woman who was angry in physical therapy, I believe, and with a little bit of listening and a little bit of questioning, I guess, Janet, I think that's the name, figured out that the woman was upset because her mother had just had a heart attack and was hospitalized.
That was Lori.
Was it Lori?
It was,
Is that you?
that was me.
Oh, okay. You didn't have to disclose, but if you did, I think that was a classic case where the issue is something outside of the setting. And if you're patient enough to ask a little, listen a little, you may get the reason behind the person being upset. And the upset may be a mixture of anger and concern and sadness, not just one thing. But that's classic for me in that what's presented is often just the top of the iceberg, so to speak, that everything else that's important is underneath that you have to dig a little bit for and have to work to get and understand. Let's look at that protocol that Drummond points out, and then maybe we could do that role playing, right? This is the procedure. This is what you do, he says. It's a 6-step procedure that always works when you're encountering an angry patient or a patient that's upset, not particularly angry, but upset for some other reason. Perhaps they're sad, right? The first thing he does is recognize and articulate that they're upset, right? That's where we said if something is out of the ordinary, you need to notice it and probably remark on it. But sometimes it's obvious. You don't have to watch or look very carefully. The person is clearly upset. So you say to them, you seem very upset. Is there something that's upsetting you? Right? That's just step number one. And you listen. For many of you, because you're so active in the work you do, perhaps you don't value enough the power of passive listening or empathic listening. It is an intervention. It is a tool. It does have an effect. You look like you're doing nothing, but if you're there attending and listening, you're doing something, and it can be very important. So I think the next question is, right, he asks, what is upsetting you? And he asks the person to put it into words. Sometimes that's enough of an invention when a person talks about, well, I'm unhappy because the doctor told me something that I didn't like to hear, but I understand the importance. It's just maybe a trivial. I'm trying to find something trivial that once they say it to someone, they realize it isn't such a big deal and they're over it. But let's say it is a big deal, like that fellow who was waiting for hours or an hour in the examining room, and he states that he's very upset because he's waited a long time, and he told the staff that if he came for this appointment, he had to get out in a reasonable period of time because something else was pending. So you've heard now what the upset is. He's put it into words. What's the third step there? Somebody else give that to me. The third step is a really important one, a critical one. It's the one that was missing in that video that I talked about. What does it say there?
I'm so sorry that you feel that way, that happened.
That's right. I am so sorry. Powerful words. I'm sorry that happened. I'm sorry that you feel that way. I'm sorry about something, not apologizing because there's been a great mistake now that we have to own up to, but just that I want you to know that I'm sympathetic to the situation you're in, right? Can you say I'm sorry? How many of you can say I'm sorry? Well, this is a special group. That's why you could say it, you know? Okay. All right. Let's see. The fourth one. What's the fourth thing? What would you like me to do about it? Right? That's very powerful. I don't know how you want to put that, because that could be accusatory. Melanie, what do you want me to do about it? Doesn't that sound mean? That's not the way we want it to come across. We want to say, is there anything that I could do to help you with that? Is there anything I can do for you under the circumstances? Something like that. They may say something very unreasonable that you cannot do. Yeah, change your schedule. Change the way you do medicine so that I don't have to wait for an hour. Well, great. Well, I can't do anything about that. But what I can do is help you get an appointment where you might not have to wait so long. And we'll take care of that next time. I'll also let the staff know that that's important to you. When you say you have a scheduling issue, that we have to pay attention to that and follow up on that. Right? And then what's the final? If there's 4 and 5 steps there, 4 is tell me what you want me to do about it, or what you would like me to do about it. But they're likely to give you something you can't do. So then you say, I can't do that, however, I can do this, right? And that's number 5, what you can do. It's a very specific intervention. And then number 6 is what? Thank you for sharing it with us, because we always want to improve. We want things to be better. We want you to be happy. We want you to get the very best care you can. That's consistent, Valerie, isn't it, with that program that you want to tell the patient, okay? Who's going to do it with me? Who's going to do it? Mary, you going to do it? Sure. Mary and I know each other from way back. What do you want to be, the patient, the angry patient, or the person who's dealing with the angry patient? You want me to be the angry patient? Okay.
Sure. What do we do?
So, well, I'll just stand here and you walk in the room, right? And I'm acting a certain way. Go ahead, walk in the room.
And this is a patient waiting in a room, waiting to be seen by the doctor.
Right.
All right. I'm sorry that you've had to wait. The doctor should be in very shortly.
Yeah, how sorry are you?
I'm so sorry. There's,
Now do the first step. You got to ask me what I'm upset over.
what is it that you're upset about?
Well, I have waited a long time, but the person up at the front desk wouldn't take my insurance card.
I'm
That's
sorry about
perfectly
that.
okay. It's a good
I can
card.
look into it for you, and then we'll find out what happened.
Well, I don't want you to do that because we already settled it. I want you to reprimand that person.
Okay, I will bring it to the attention of our office manager so she can talk to the employee.
I'm still not happy.
Give him a treat. We have snacks.
I'm giving you a particularly hard time, but at some point you have to say, I'm sorry, and then shut it down.
Right, I
Right.
can no longer diffuse the issue or,
Nothing more I can
your
do.
complaints.
There's nothing more I can do. I'm really sorry you were upset.
But I think you have to come up with a delicate way of saying that.
Absolutely. Everything is delicate.
That's the true, the wording of it is, to me, is the most critical of
Absolutely.
what I would
Absolutely.
have to say to that patient.
That's right. And you'll do it better there when you're up here. It's not natural for you, but you've told me how you work with elderly patients, and it's perfect, and it is delicate and appropriate. But now there's the last part of this. What's the last of the 6 steps?
Thank you for sharing your worries with us.
Thank you. Thank you for sharing your concern, your worries, and I hope it gets better for you, or we hope we can do better next time, okay? And then if there's something else, there might be a follow-up if you care. If you think this person was upset enough that today about something important, but I'm going to say something about that. It's important to them, not to us, right? You may call that evening and say, I'm just concerned about you. How you doing? It's very interesting. One of my friends is an endodontist, and he does root canals, and he calls always in the evening to see how his patients are doing, and he's recommended how effective this is in terms of the response he gets from the patients. He can't get the other doctors to do it. Nobody wants to be bothered. I guess when we're done working, right? But every once in a while, a little bit extra would go really well. Action plan that we mentioned before. If we have a situation where there's potential violence or actual violence, what should we do? Now, I'm not going to answer that for you. That's a really big problem. But your office should have an action plan. If somebody comes in the front desk with guns or shooting, what do? Just jump under the desk? Who's responsible for calling for help? Who's responsible for helping somebody that's been hurt? What do you do for the patients who are out in the waiting room if something like that happens? Do you have an action plan? Has the staff discussed it? And do you know what you're going to do? Have you practiced it at all? We have fire drills. Nowadays, I think we're going to have violence drills because this is a potential problem. This guy may have been that way. He left and you're lucky. Sometimes when patients leave that you can't work with, you're lucky that they've left. That's about the best outcome you can get. Very good. Okay, well, thank you very much. I think.